Tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko Carmela Petagna tōku ingoa. I'm a Senior Manager here at the Health Quality and Safety Commission and oversee a number of our national quality improvement programs.
Tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko Jane Cullen tōku ingoa. I'm the Quality Improvement Advisor on the Primary Care Program Whakakotahi.
The Commission is an independent Crown entity and has been established for 10 years. It works across the health and disability sector in Aotearoa, New Zealand, to improve health services and works towards achieving the triple aim. The analogy we often use to describe our work is we do this by shining the light through data intelligence and evaluating our impact, and by lending a helping hand through our improvement work and partnering with others. This is the vision and mission of the Commission, which has recently been refreshed. We hold a unique role in the health sector and deliver our work in partnership with others, described in 4 approaches: how we involve, inform, influence, and improve. Whakakotahi is part of the Commission's Primary Care Quality Improvement Program. The concept was to work as one with the sector, to support primary care with improvement projects that they identified as being important to the populations that they serve. The work commenced at small scale, aimed at building on the work that they were already doing and amenable to achieving scale and spread over time. We used a number of methods to capture the work, including visual storyboards, as you can see here. Our commitment, and as agreed by our expert advisors, focused on 3 key criteria that all projects had to address. These were equity, integration, and consumer engagement. A co-creation approach was adopted from the outset of the program. It was guided by primary care experts and consumers with feedback from improvement teams to enable rapid learning and adaptation. Consumers were part of the expert advisory group on the project selection panel for all projects across all 3 years. The program theory of change rests on the drivers for achieving integration through partnering with Māori, sector leadership, driving improvement capability, consumer co-design, and doing all this to achieve reduced harm and variation. The collaborative methodology was adapted to meet the specific needs of the people and context. Evaluation was a key part of the process, and we had an independent provider partner with us from the outset of the program. We did this in a formative way, which meant that we could distill learning each year through progress reports and adapt and refine the program and processes as required to ensure that what we were doing was fit for purpose and the sector we were working with. This was a 3-year journey. Some of the refinements adopted were around simplifying our EOI process, increasing our criteria weighting for equity, and improving our own cultural competence as a team.
After the first year, all of the projects came from health providers servicing areas of high deprivation and/or Māori and Pacific populations. In the first year, we started with a focus on general practice services, but broadened our criteria to include pharmacies and other primary care providers in the subsequent years. We encouraged teams to develop projects involving other providers and had several joint general practice, pharmacy, and primary secondary care projects. In 2019, the increased weighting given to equity saw 4 Māori health organisations and the Tongan Health Society among the 9 projects selected. As you can see here, most of the projects focused on chronic conditions, and diabetes was a key area of focus across all 3 years. I'm just going to share some successful project outcomes. Here you can see a project from a Pacific general practice and community provider whose project aimed to reduce skin and soft tissue infections in the Tuvaluan community. They were able to narrow the equity gap between the Tuvaluan population and other Pacific Island groups and the rest of the community, as you can see on this graph. This is a Māori general practice example, improving the management of gout for Māori patients diagnosed with gout who were not receiving the standard treatment. This next one is a pharmacy project with Māori and Pacific youth who set and subsequently achieved their own asthma control target scores. Capability building was one of our key aims, and over the 3 years, 53 primary care workers were educated in improvement science. We sponsored 1 or 2 people from each team into a formal course, in addition to the 3 learning sessions and on-site support provided as part of whakakotahi. Team's feedback tells us that the gains in quality improvement capability do not simply drop off after the program ends. The tools and mindset that comes with gaining confidence and experience and applying quality improvement methodology continues to be evident in their work afterwards. Across the 3 years, 17 out of the 18 projects were equity focused. And while not all of the projects achieved their stated aims, even those who did not achieve their aims would still rate the project as a success because of the progress they made towards achieving their often aspirational aims. Understanding improvements in health equity is a long-term journey that is best achieved through a systems approach and subsequently understood in the same way, which is difficult to achieve within the constraints of the program timeframes. Here we have a video of one of the consumers sharing her experience on being involved in whakakotahi.
My name's Ali Sinclair, and I've been on the methadone program for quite a while now, about 20 years, and I have quite a few health issues. I think it's important for us, for a consumer, to be part of the project, is because we're the ones that are taking the medication, we're the ones that have the experience, and we're the ones that can let the health professionals know what we're going through. It's been really good. Going to the seminars with the ladies, being asked everything about what they wanted my input, it made me feel very proud to be part of it. Well, the benefits and the outcomes of the project would be that we will not be losing 20 years off our lifespan. We'll be getting looked after just like everybody else, and it'll be equal health to everybody, when you're on the methadone program. I feel very proud to be asked to be part of it. And to have it's enlightened me to be asked to be part of the project. I feel very privileged. I felt like I've been listened to, being there and as a consumer, definitely.
Integration was a key principle for the projects. Evaluation survey data identified that across all 3 years, everyone considered their project to have a positive or very positive impact on integration, with some case examples demonstrating this far more explicitly than others. There were some barriers encountered by the participating teams, and some of these are of particular concern in the primary care setting, such as the limitation of primary care data and data infrastructure. However, participating in whakakotahi provided the opportunity to build these skills and capabilities. All of the teams valued the support from the Commission and the flexible approach that we developed after the initial year. Before the 3rd year, we partnered with a Māori organisation to provide cultural advice and support for the team. This helped build the cultural capacity of our team, accelerate the focus on equity, and ultimately improve health equity for Māori. The partnership was important in supporting Māori providers to use their Māori models within the improvement program.
Building on the findings of our evaluation during 2021, we are looking at how we strengthen the system enablers to grow scale and spread of quality improvement in primary care. We have a number of projects underway that will help us support a consumer co-design program in primary care, develop a capability building program that reflects the unique context of primary care in Aotearoa, build a national measures library to influence equity-driven improvement decisions and improvement activities, and develop a kaupapa Māori quality improvement framework. These are works in progress that we hope will support improved quality improvement at scale in primary care. E hara taku toa, I te toa takitahi, engari, he toa takitini. Kia ora, thank you very much.
Kia ora.